I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. 20 million Americans suffer from some kind of thyroid disorder. Many don't even know it. What symptoms are a red flag? This is the People's Pharmacy with Terry and Joe Graydon.
Levothyroxine and desiccated thyroid extract are among the most frequently dispensed medicines. Why is hypothyroidism so common?
An overactive thyroid gland is also a big problem. It can affect the heart, the bones, and the digestive tract. How is hyperthyroidism usually treated?
We speak with one of the country's leading experts on treating thyroid disease. We'll also talk with a functional medicine practitioner about managing hyperthyroidism.
Coming up on the People's Pharmacy, insights into living with hypo and hyperthyroidism.
In the People's Pharmacy health headlines, COVID-19 has lasting consequences for many people long after they've recovered from the acute phase of the illness. Most studies of long COVID, also called post-acute sequelae of COVID, have not focused on specific age groups. Now, a study of more than 130,000 Medicare Advantage patients who were diagnosed with COVID-19 shows that lingering problems are common. The researchers report in the BMJ that one-third of these individuals over 65 had new or persistent health problems in the 4 months following their recovery. The most common difficulties were trouble breathing, fatigue, high blood pressure, memory problems, kidney injury, mental health disorders, blood clots, and heart rhythm disturbances.
Adolescents are not immune to long COVID. One study from Denmark tracked 15 to 18-year-olds who had a positive COVID test between January 2020 and July 2021. Over 6,000 young people volunteered, along with more than 21,000 teens who had not contracted COVID. They served as the control group. Almost half of the youngsters who had caught COVID-19 reported symptoms lasting for months. They included headache, fatigue, loss of appetite, trouble breathing, and trouble remembering or concentrating. They reported more school days missed due to illness compared to the controls.
Another study from the UK analyzed data on youngsters between 11 and 17 years of age. More than 3,000 adolescents who tested positive for COVID were compared to 3,700 who tested negative. Data were collected for 3 months after a positive test. Those who had COVID were more likely to experience multiple symptoms, especially tiredness, headache, dizziness, loss of the sense of smell, and shortness of breath.
Poor sleep is associated with hypertension, heart disease, diabetes, impaired immunity, and obesity. Can strategies to increase sleeping time make a difference for weight control? Researchers conducted a randomized trial to see whether improving sleep duration could impact caloric intake. The volunteers were overweight and normally slept less than 6.5 hours a night. One half were provided sleep hygiene counseling aimed at extending their sleep duration. After 2 weeks, the intervention group improved sleep time by 1.2 hours. They also consumed significantly fewer calories. The investigators concluded that improving and maintaining healthy sleep duration over longer periods of time could be part of obesity prevention and weight loss programs.
Most people have heard about the importance of the gut microbiome for overall health. That usually means the range of bacteria found primarily in the large intestine. A new study from Japan examined the relationship between the viruses in the gut microbiome and autoimmune diseases. The researchers found that lower diversity of bacteriophages was associated with more rheumatoid arthritis and lupus. Bacteriophages are viruses that attack bacteria.
Tart cherries are rich in polyphenol compounds with antioxidant and anti-inflammatory activity. To find out if they might have cognitive benefits, scientists recruited 50 healthy middle-aged volunteers. These individuals went through a comprehensive computerized battery of cognitive tests before the investigators assigned them to consume 30 milliliters of Montmorency cherry concentrate or a look-alike placebo twice daily for 3 months. They took tests designed to examine the same cognitive capabilities at the close of the study. The researchers found that those taking the cherry concentrate were better able to sustain their attention. They also reported feeling more alert with less mental fatigue. There did not appear to be any increase in blood flow to the brain, and the cherry consumers did not sleep longer or better than those on placebo. The investigators summarize, "These data provide new information that bioactive foods that are rich in anthocyanins and other polyphenolic compounds can have an anti-fatiguing effect during periods of high cognitive demand, which are beneficial in daily tasks requiring vigilance." And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Your thyroid gland affects every cell in your body. The hormones it produces govern how you utilize energy. They also affect your heart rate, your digestion, your brain function, and your weight. When this crucial organ is either under or overactive, there are important consequences. What are the most common symptoms and the most effective treatments?
To learn more about hypo and hyperthyroidism, we turn to Dr. David Cooper. He's the director of the Thyroid Clinic and professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism at the Johns Hopkins University School of Medicine. Dr. Cooper is the past president of the American Thyroid Association and the recipient of the American Thyroid Association Distinguished Services Award.
Welcome back to the People's Pharmacy, Dr. David Cooper.
I'm looking forward to our discussion today.
Dr. Cooper, 20 million people have a thyroid disorder, and that may be an undercount. Why do you think hypo and hyperthyroidism are so common?
Well, that's an excellent question, and I wish I had an answer for you. There are many reasons why people have thyroid disease. By far and away, the most common cause many, many years ago in the world was iodine deficiency, which was rampant in the United States and many other countries on Earth. But in the United States now, just the normal American diet has plenty of iodine, so that really isn't the cause. Most of the thyroid diseases that we see in our clinics are what we call autoimmune thyroid diseases. And the most common by far is something called autoimmune thyroiditis or Hashimoto's thyroiditis, which is the main cause of someone having an underactive thyroid. And then another quite common autoimmune thyroid disease is known as Graves' disease, which is an overactive thyroid, again, an autoimmune condition. Both of these tend to run in families. Both of these tend to be more common in women. But if you're asking me why is it so common in the general population, I can't tell you. All I can say is that you're right. 10 to 15% of all people have a thyroid problem. And as far as, let's say, Graves' disease is concerned, 1 out of every 50 women at some time in her life will develop Graves' disease. So you're right. These are very common, and they're often first diagnosed by primary care physicians, family physicians, and even particularly gynecologists who are very tuned into the fact that women predominate in having thyroid disease. So they're often the ones who bring a thyroid problem to attention first.
Dr. Cooper, do we have any idea why women are so much more likely to have thyroid disease?
We do not. Some people have hypothesized that somehow it's related to estrogen levels, somehow making the thyroid or the person more susceptible. But honestly, I wish I could answer your question, but I think it's true that since thyroid disease is common and since the most common thyroid diseases are autoimmune, I think it's safe to say that most autoimmune diseases, let's say rheumatoid arthritis or psoriasis or Crohn's disease are more common in women than in men. So there's something about being a woman that makes a woman more susceptible to autoimmune problems in general.
Dr. Cooper, could you quickly run through the most common symptoms of both hypo and hyperthyroidism? So some of our listeners who may never have been diagnosed can go, oh, that might be me.
Sure, of course. Since the thyroid hormones regulate a person's metabolism, the symptoms that would be associated with a low thyroid are the typical symptoms you might think of in a person with a low metabolism. So they might gain weight because they're not burning off calories rapidly enough. They might feel sluggish and tired. They might have constipation. They might have a low pulse rate. Their hair and skin may be dry. On the other hand, in a person who has an overactive thyroid, their metabolism would be speeded up, and so they might notice that they're losing weight or that they feel hot when everyone else around them feels normal. Rapid bowel movements or more frequent bowel movements are seen. A tremor, a sensation that they have a rapid pulse rate, difficulty sleeping, nervousness and anxiety. These are symptoms of an overactive thyroid. Now, of course, many of the things that I just listed are symptoms that people have anyway. Even healthy people can feel tired or gain weight or lose weight or, be anxious. And so even though a person should have their thyroid checked out when they develop any of these symptoms, very often the thyroid levels are normal. And then the patient and the doctor need to go through some diagnostic tests to try to figure out what really is going on. But yes, of course, the thyroid should be something on the list of things that you exclude when a person has any of those symptoms that I mentioned.
Dr. Cooper, we just were talking about the fact that women are especially susceptible to thyroid problems, and there is one classification of symptoms that we didn't mention here, but because it refers exclusively to women, I think we should. What's
Sure.
the impact on the menstrual cycle?
So there's two things to talk about. One is the impact on the menstrual cycle, and I'll just mention that briefly. Women who have hypothyroidism often have heavier periods and more prolonged periods and irregular periods. And women who have an overactive thyroid sometimes have lighter periods or lose their periods altogether. And then another thing that kind of is brought to mind by what you just asked me is the difficulties that we have in women who have already a diagnosed thyroid problem, either hypothyroidism or hyperthyroidism, who get pregnant. And there is a whole special set of circumstances where we have to adjust their medications and follow the woman very carefully during the pregnancy, because a thyroid problem in the mother, if it's not managed properly, can have an impact on the developing fetus.
Now, Dr. Cooper, there's one odd side effect you haven't mentioned, and I don't know how common it is, but it's always struck me as, wow, how odd and how interesting. Some people lose the outer third of their eyebrows, and that's a tip-off to hypothyroidism. Why do you think that happens?
Yes, there's a name for that which escapes me right now, but I don't know the answer to your question. But there are certain, specific physical findings that one sees when people have an overactive or underactive thyroid, and I can't tell you exactly why people have that. But what you just said brings to mind another symptom that's really not specific to hyperthyroidism per se, but is seen in Graves' disease, which is the most common cause of hyperthyroidism, and that is the eyes becoming more prominent, a person developing problems with their vision, swelling and irritation of their eyes. This is called thyroid eye disease, and it's only seen in people with Graves' disease.
You have had hyperthyroidism yourself. What was it like for you?
Well, I had Graves' disease when I was in college. And of course, I didn't know I had Graves' disease. This is when I was a senior, and I was under a lot of stress at that time due to a variety of factors. Trying to get into medical school was one of them. And at any rate, I just started losing weight. I had a voracious appetite. No matter how much I ate, I lost weight. In fact, I remember eating 2 pints of ice cream a day. thinking it was kind of a fun thing to have. And no matter how much I ate, I lost weight. I was nervous. I couldn't sleep. And anyway, I actually went to the University Health Center to talk to the doctor there about my problem. And he just said, "Oh, you're just under a lot of stress because you have exams coming up." So I wasn't diagnosed until I graduated, and I went home for the summer. And my mother took one look at me and took me to our family doctor, and he diagnosed me with Graves' disease in about 30 seconds. And there's a whole other, story I could tell you about my treatment. But yes, that's how I presented. It was a very stressful time, which we know is a trigger. I didn't mention this, but my father and both my mother and father had Graves' disease. So there was a family history in my case. And so I think those factors, the stress and the family history, are what triggered it in me.
And Graves' disease can be a challenge to treat because there are a couple of different ways of going about it. And there's a bit of a difference between what they do in Europe and in other countries and what has been popular here in the U.S. So I would really love for you to tell us first what you did to treat your hyperthyroidism, or what your doctor did to treat your Graves' disease. And then after the break, we'll talk about some of the other options.
Sure. Well, the problem with treating Graves' disease is simply that unlike other autoimmune diseases where there might be a drug to suppress the immune system, let's say for rheumatoid arthritis, where you see on TV the commercials for various autoimmune diseases like rheumatoid arthritis or psoriasis, there is no treatment for Graves' disease that gets at the cause, which is an autoimmune problem where the immune system stimulates the thyroid. So the treatments that we have are very old treatments. There's really nothing new on the horizon, really. And it involves medicines that can impact how the thyroid makes thyroid hormone. They kind of poison the thyroid, if you will. And then the other two treatments are destructive. So there's a treatment called radioactive iodine, where you take some iodine that's been radioactive and it gets into the thyroid and destroys it, or surgery, which has been around for more than 100 years. I was treated with medication, and I took one of the medicines, and within a few weeks, I developed a very, very severe allergic reaction. And so that medicine was stopped, and I was switched to there are two medicines, so I was switched to the other one. The first is called methimazole, to which I was allergic, and then I was switched to PTU, the other antithyroid drug.
You're listening to Dr. David Cooper, Director of the Thyroid Clinic and Professor of Medicine and Radiology in the Division of Endocrinology, Diabetes, and Metabolism at the Johns Hopkins University School of Medicine. Dr. Cooper is the past president of the American Thyroid Association and the recipient of the American Thyroid Association Distinguished Service Award.
After the break, find out how Dr. Cooper got his hyperthyroid condition back under control.
One treatment is radioactive iodine. Does it carry risks?
What are the long-term consequences of having your thyroid hormones out of balance?
Are there supplements that help? Are there some you should avoid if you have thyroid disease?
We'll get Dr. Cooper's vision of the future for people with thyroid disorders.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. What happens when the thyroid gland rages out of control? Our guest has had personal experience with hyperthyroidism.
We're talking with Dr. David Cooper, Director of the Thyroid Clinic and Professor of Medicine and Radiology in the Division of Endocrinology, Diabetes, and Metabolism at the Johns Hopkins University School of Medicine. Dr. Cooper is the past president of the American Thyroid Association.
Dr. Cooper, you were just describing how you were treated for your Graves' disease. How did it finally resolve?
Well, if you have an hour, I can tell you about it. But just to be serious, I was switched to a different drug And I did okay on that. And after about 2 years of being treated with the other drug, it's called propylthiouracil, or PTU, the drug was stopped because sometimes people have what's called a remission, where the immune problem kind of just goes away after a couple of years of treatment. And so when I was in medical school, I took PTU for a couple of years, and then my doctors recommended that I stop it. So in my third year and fourth year of medical school, I was on no treatment at all, and I was doing fine. Then I started my residency, and again, it was a very stressful situation, and I relapsed, which is something we see, and so I was restarted on propylthiouracil, and within a few weeks, I developed, again, a very severe allergic reaction called agranulocytosis, where I had essentially zero white blood cells and had a severe, severe infection of my throat.
That can be life-threatening.
It can be. So I was admitted to the hospital. I was treated with intravenous antibiotics. And then within a week or two, I was treated with radioactive iodine, because at that point, I couldn't take any medicines. I was allergic to both of the medicines. So I received radioactive iodine. And then within a month or two, I became hypothyroid, which is the natural result of radioiodine therapy. And I've been on thyroid hormone replacement therapy for the last 40 years, doing fine.
Well, before we get into the testing and the importance of treating both hypo and hyperthyroidism, there's been a lot of controversy around radioactive iodine in the last couple of years. Some articles that appeared in JAMA Internal Medicine and some other prominent journals suggesting that maybe there's a slight increase in cancer as a result of that radioactive iodine. Your thoughts?
Yeah, so this is something that's been a concern for, decades. So radioactive iodine was introduced as a therapy in the 1940s. And the idea is that the thyroid uses iodine to make thyroid hormone. And if we give a person iodine that's been made radioactive, the thyroid can't tell the difference between the iodine, in a tuna fish sandwich and the iodine in the pill that's radioactive. So it just takes it up. And since it is radioactive, it radiates the thyroid and ultimately damages and destroys the thyroid. And since it's a form of radiation, people thought, gosh, maybe this could be a cause of cancer later on in life. So there was a very large study that was published in JAMA in the 1990s, where they followed many thousands of people that had been treated with radioactive iodine or surgery or antithyroid drug therapy, and did not find much in the way of any increase in cancer. But in a reanalysis of the same data in the paper you just referred to in JAMA, I think it was JAMA Internal Medicine or whatever, I can't remember which JAMA it was, they did find that there may be a slight increase in breast cancer and other solid tumors in people that were treated with radioactive iodine compared to the background population. Now, the caveat of this is that when they then re-examined all the data, including people that only received antithyroid drug therapy, for example, there was also a slight increase in the risk of cancer. And so whether it's the radioactive iodine or whether it's just having a thyroid problem like Graves' disease, somehow there may be a slight increase in the risk of cancer in those individuals, but it may not be specifically related to the radioactive iodine, although I know that certainly there's a rationale for radiation exposure in cancer. In that study, you'll see that there was also a higher risk of cancer in people that were treated with antithyroid drugs.
Dr. Cooper, I'd like to ask you about the laboratory tests that a doctor would use to make a diagnosis, whether it's the thyroid being too overactive or the thyroid being too sluggish. They use some of the same tests. Could you explain those laboratory tests to us briefly, please?
Absolutely. And I just want to say that we're really lucky to have such fantastic laboratory tests that make the diagnosis of thyroid disease so simple and straightforward. So, of course, we want to measure the level of thyroid hormone in the blood. This is the hormone that the thyroid makes. There are two of them, actually. One is called thyroxine, or we abbreviate it T4, and then there's another one called triiodothyronine, or T3. So these are the actual thyroid hormones that regulate your body's metabolism. But the thyroid, like many of the glands in the body, doesn't just work on its own. It's regulated by the pituitary gland, which is in the brain. And the pituitary secretes a hormone into your blood called thyroid stimulating hormone, or TSH. And that's what actually tells your thyroid to work and to make thyroid hormone and to release thyroid hormone. So let's say a person has a thyroid problem where they have some inflammation in the thyroid and their thyroid isn't working quite as well as normal. It's sort of sluggish and the thyroid levels are low. The pituitary can sense that because it's monitoring the thyroid, and the pituitary says, gee, I better get her or his thyroid to work harder. So the TSH level will go up in an effort for the thyroid to make more hormone. And so when a person has an underactive thyroid, the thyroid hormone levels are on the low side, and the TSH will be elevated. So it goes in the opposite direction of the thyroid. On the other hand, if the person develops Graves' disease, let's say, and the thyroid on its own, because of the autoimmune stimulation of the thyroid, starts making too much thyroid hormone, the pituitary senses that, and it says, gosh, there's too much thyroid hormone. I don't need to make the thyroid work so hard. And so the TSH level will be low in a person that has an overactive thyroid. So this is confusing to many people because it's, the opposite. So the TSH is high when the thyroid is low, and the TSH is low when the thyroid is high. But doctors use these tests. They're very sensitive and very specific, and, they're very, very helpful in diagnosing thyroid problems. I will say that many of your listeners may be taking a vitamin called biotin. This is, I think, vitamin B9, if I'm not mistaken, or vitamin B7. I can't remember. But many people, especially women, take biotin because of hair loss or problems with their fingernails. And biotin can interfere in the test tube with many of the tests that we do, including the thyroid test, but also vitamin D levels and other things that we measure. It doesn't affect the results in the person. It just affects the results in the test tube. It can make the test come out looking falsely abnormal. So if any of the listeners do take biotin, before they have any blood tests done that might be ordered by their doctor, they should stop taking the biotin for at least 72 hours.
Now, Dr. Cooper, you mentioned that you lost a lot of weight when your thyroid was in overdrive. And I suspect there are a lot of people who go, well, that would be kind of cool. And there are a lot of people who go, yeah, when my thyroid is sluggish and it's not working well, I just don't feel very good. So there's a reason for why I want to treat my thyroid. What are the long-term consequences of either hypo or hyperthyroidism? Why should we treat it?
Well, there's certainly many reasons. First, because as you said, people just don't feel well if they're significantly hypothyroid or hyperthyroid. And we want people to feel their best and function at their highest level. But more importantly, or at least equally importantly, there are negative effects on the body if the thyroid levels are maintained at too low or too high a level. Let's take an overactive thyroid first. If this is not treated, this can lead to bone loss in men and women, and especially in postmenopausal women who have osteoporosis. It can make it worse. And also for people that are older, and when I use the word older, I mean people in their 50s and 60s, but especially people in their 70s and 80s, it can trigger atrial fibrillation, which is a very, very serious heart rhythm disturbance that can cause lots of medical problems. So in addition to how they feel, we want to protect people's bones and cardiovascular system and treat hyperthyroidism. And similarly, when people have untreated hypothyroidism, in addition to not feeling their best and functioning at their best level, it turns out that because the thyroid hormones regulate your body's cholesterol and other lipids, people who have untreated hypothyroidism have high cholesterol and premature atherosclerotic heart disease. And so there are studies that show they have a higher risk of cardiovascular disease and death if they have untreated both hyper and hypothyroidism.
So it sounds as though it really does make sense to try and hit that sweet spot.
Absolutely. We don't want to overtreat people because then it's the same as having an overactive thyroid if we take too much thyroid hormone. On the other hand, we don't want to have people undertreated either because then they may be exposed to the long-term negative consequences of too low a thyroid. And just as long as we're talking here, I will mention that especially in the treatment of hypothyroid, it's sometimes very difficult to be sure that the patient is on the right dose of medicine. And there are studies of patients who take thyroid hormone, and it turns out that in about 30 to 40% of the time, their thyroid levels are not normal. That is, they're being inadvertently overtreated or undertreated. Now, whether that's due to the doctor making a mistake in the dose or the patient not taking their medicine properly, that we don't know. But it's very common to see patients treated with thyroid medication who do not have normal thyroid levels because of problems with their dose of medication or taking it properly.
When it comes to taking thyroid medicine, this is actually a topic that we have had a number of listeners ask us questions about. What's the right way to do it? Do you have to get up early in the morning and take it an hour before your coffee, or is it better to take it at bedtime before you go to sleep?
This is really such a great question because I just can't tell you how many times I have patients who just torment themselves, setting their alarms, at 4:00 in the morning so they can get up and take their pill and then go back to sleep again, or maybe not go back to sleep again. I mean, what we tell people is that they should take the pill on an empty stomach at least 30 minutes before they eat. They don't have to take it hours before they eat, and they don't have to wait hours after they take the pill to eat. Because food can interfere with the absorption of when we talk about thyroid medicine, we're talking about levothyroxine, not the drug to treat an overactive thyroid. And so, but some people just have a very hectic morning and they have to get out and take their kids to school. And so there's absolutely no reason why a person cannot take their medicine at bedtime. That way it's separated from food because they ate dinner hours before. And there's studies that show that it's just exactly equivalent in terms of, the thyroid hormone levels if a person takes it at bedtime or not. And I actually had a patient this morning who told me that her doctor said you cannot take the medicine at bedtime. You only can take it in the morning. This just is not true. So for those people out there who have trouble getting up and taking their medicine and having breakfast and waiting 30 minutes, that you can take it at bedtime.
Oh, that's good news.
And then the other thing is you shouldn't, and I'm sure people know this, there are certain medicines and supplements where you shouldn't take it with the thyroid medicine. So it's better to take it alone. For example, and the most notorious ones are calcium supplements and iron supplements. And many people do take these supplements. And so if a person is taking these, they should separate them from their thyroid medicine by at least 4 hours. And again, that's why taking the medicine at bedtime makes so much sense, because you can take your iron in the morning and your calcium with lunch and dinner, and then you can take your thyroid medicine at bedtime.
Another question, Dr. Cooper. Does COVID-19 contribute to autoimmune thyroid disease?
That's a terrific question also. And I don't know how you come up with all these great questions, but as you might imagine, in every field in medicine, there have been articles now about the effect of COVID on lung function, on kidney function, on heart function, on brain function. And of course, there are articles on the effect of COVID infection on the thyroid as well. And there may be an increased frequency of autoimmune thyroid disease in people that have COVID infection. That's been reported, especially Graves' disease. And also, there's a condition called granulomatous thyroiditis. This is, or called subacute thyroiditis is another name for it. This is a viral infection of the thyroid. And many different viruses have been implicated in this condition. And COVID now has too. So there are people that have had COVID infections who appear to have infection of their thyroids in addition to the rest of their body. So yes.
So we could be seeing over the course of the next couple of years a lot more thyroid problems than we normally would expect just because so many people have been infected by COVID.
I actually hadn't thought of it in that way, but I think you're very correct. So yes, you're right. That's millions and millions of people that may be at risk, not only for thyroid problems, but other long-term problems as well that we don't even know about yet.
Dr. Cooper, as you look back over the last 30, 40 years and look forward over the next couple of decades, what do you imagine for the future of both hypo and hyperthyroid? Are we going to see newer, better treatments, better understanding of what's going on?
So I'll put on my binoculars to look into the future. Let's talk about hypothyroidism first. We already have a great treatment for hypothyroidism, which is levothyroxine. It's a medicine that's been around for many decades. It replaces the thyroid pretty well. It's easy to take. It's cheap. But as you know, there are some people who don't feel completely normal taking levothyroxine. And some people have advocated taking T3 or triiodothyronine in addition to the levothyroxine, which may make some people feel more normal. And the problem with taking T3 is that it has a very short duration of action. And so you have to take it twice a day, and the levels kind of peak and fall during the day. And what we really need is a steady, long-term T3 pill that lasts a long time in the blood. And that is currently being worked on by a variety of investigators. And I predict, if you want me to look into the future for that in a few years we will have a long-acting T3. They'll probably combine it with a T4 pill or levothyroxine, and there'll be a pill that will be able to replace the thyroid better than we have right now. And in other words, a pill that will duplicate the thyroid's normal secretion better than levothyroxine monotherapy. If you want me to look into the future, like in 100 years for hypothyroidism, I could imagine stem cells that are grown in a laboratory to turn into thyroid tissue and then be implanted in a person to make thyroid hormone, just like we have people getting pancreas transplants now for treatment of diabetes. I'm talking about a laboratory way of giving a person back a thyroid. I could imagine that could happen. As far as hyperthyroidism is concerned, for many autoimmune diseases, there's a treatment that is getting at the basis of the disease. That is attacking the immune system and suppressing it so the person, let's say, has a decrease in the inflammation of their joints for rheumatoid arthritis, or a decrease in the inflammation in their intestine for Crohn's disease. We don't have that immunosuppressive treatment for Graves' disease. All we have are the treatments that we mentioned, the medicines that kind of poison the thyroid, or radioiodine or surgery that destroys the thyroid. And I predict that there will be drugs that will treat Graves' disease by getting at the exact cause, which is the immune system stimulating the thyroid, either by interfering with the antibodies that stimulate the thyroid or by suppressing those specific immune cells that are abnormal. But that's what I predict for the future for Graves' disease.
Dr. David Cooper, thank you very much for talking with us on the People's Pharmacy today.
Thank you for having me. It's been a real pleasure to talk to you.
You've been listening to Dr. David Cooper. He's the director of the Thyroid Clinic and professor of medicine and radiology in the Division of Endocrinology, Diabetes, and Metabolism at the Johns Hopkins University School of Medicine. Dr. Cooper is the past president of the American Thyroid Association and the recipient of the American Thyroid Association Distinguished Service Award.
After the break, we'll talk with Dr. Eric Osansky about complementary medicine for thyroid problems.
How did he get interested in Graves' disease?
He'll share his action plan to restore health for those with Graves.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
Today our topic is thyroid disease. Are there any complementary treatments for hyperthyroidism?
To get additional perspective, we turn now to Dr. Eric Osansky. He's a chiropractor, clinical nutritionist, and a certified functional medicine practitioner treating people with autoimmune thyroid conditions. His books are Natural Treatment Solutions for Hyperthyroidism and Graves' Disease and Hashimoto's Triggers.
Welcome to the People's Pharmacy, Dr. Eric Osansky.
Thank you for inviting me. I look forward to our conversation.
Dr. Osansky, how did you get interested in hyperthyroidism?
Well, I personally was diagnosed with hyperthyroidism in 2008. And so that's how I became interested in hyperthyroidism, just by my self-experience.
What was it like?
Well, it was definitely not a fun situation dealing with the symptoms of hyperthyroidism. I had an elevated resting heart rate. I had palpitations, increased appetite. I lost a lot of weight, lost approximately 42 pounds. And, initially I did not know that I had hyperthyroidism, so I was attributing it to other things. But yeah, it was very, very uncomfortable situation.
What you describe is not unusual. A lot of people have thyroid disease and they don't realize it and often get misdiagnosed. It takes a long time. It takes a long time, whether it's hypo or hyperthyroidism, to figure out what's going on.
I agree. Probably more so with hypothyroidism because a lot of people dismiss fatigue and brain fog as being just maybe working too hard. With hyperthyroidism, it wasn't too long before I caught on, but at the time I was dieting, I was detoxifying, so I was attributing at least a weight loss to that. But then one day I was measuring my blood pressure, which also measured my resting heart rate, and my blood pressure was normal, but my heart rate was elevated. And then so the next few days I just kept on measuring my own resting heart rate, and it remained elevated. And then I kind of started putting the pieces together with the weight loss and some of the other symptoms, and eventually went to a primary care doctor before being diagnosed with hyperthyroidism.
Dr. Osansky, when we have written about hyperthyroidism and Graves' disease, we occasionally get a response from one of our readers saying, "What's the big deal? I'd love to be able to just maintain my weight without trying, or, even be losing weight. So why should I bother treating this condition?" Can you tell us what are the long-term health consequences of Graves' disease, which is the autoimmune condition associated with hyperthyroidism?
Sure. Well, for the hyperthyroidism itself, I will say that there are definite risks. So it does put a good amount of stress on the heart. And then also the elevated thyroid hormone levels have a negative effect on bone density. So over time can lead to osteopenia, potentially even osteoporosis. And so there are the short-term risks and long-term risks. And then when it comes to the autoimmune component, when someone has one autoimmune condition, such as Graves' disease, they are more likely to develop other autoimmune conditions in the future. And there are autoimmune conditions that are even worse than Graves' disease, arguably, such as multiple sclerosis. And again, there's a whole host of other autoimmune conditions, and there's no guarantee someone will develop another autoimmune condition, but a greater likelihood if the autoimmune component isn't addressed.
Dr. Osansky, do we have any idea what causes hyperthyroidism?
There are different causes. I mean, Graves' disease is the most common cause. So most people with hyperthyroidism, it is autoimmune. It is Graves. There are other causes such as toxic multinodular goiter, and that's when someone has multiple nodules in the presence of a goiter, which doesn't always lead to hyperthyroidism. There's also just multinodular goiter, but the toxic point the toxic indicates that someone has hyperthyroidism in the presence of the multinodular goiter. And then there's subacute thyroiditis, which is usually viral induced, but could also be bacterial induced. But those are some of the potential causes. I don't know if you wanted me to go into actually like triggers of hyperthyroidism, or you just mean the different types of hyperthyroidism?
Well, we'd be interested in the triggers. I mean, we've heard, for example, that COVID might be a trigger, and you've already mentioned some viral conditions that might trigger hyperthyroidism or Graves. And I guess I'm also interested in toxins or pollutants.
Sure. Well, it's interesting you mentioned COVID because in 2020, I think it was September 2020, where I did some research and found that COVID-19 can actually be a cause of subacute thyroiditis. And there's other viruses too, like cytomegalovirus, for example. But yeah, without question, COVID-19 can potentially cause subacute thyroiditis as well. There's also some evidence that it could be a trigger of Graves' disease. And then there's other viruses that potentially could be a trigger of thyroid autoimmunity, including Graves' disease. Epstein-Barr is one of the more well-known viruses where there's an association in the literature. And then as far as environmental toxins, mercury, there's some evidence also of mercury being a potential trigger of thyroid autoimmunity, possibly also just affecting the thyroid directly too, not just, but that's more towards the hypo side and not the hyper side. But the truth is, as you know, we're bombarded with so many environmental toxins, so many toxins in general, not just heavy metals, but glyphosate and bisphenol A, BPA, other xenoestrogens, and which speak of xenoestrogens, there's some evidence that the xenoestrogens could be a factor with thyroid autoimmunity. But I'm sure there are other toxins that are not in the literature that could also be a trigger that we're just unaware of.
Well, one of the things that has come to our attention when we have spoken to experts on endocrine disruptors, they've pointed out that cats are exceptionally susceptible to hyperthyroidism. But this is I'm going to say, and it's going to sound weird, a relatively new phenomenon because they didn't see it. Vets didn't see hyperthyroidism in cats until about 1979. And then there was a rapid increase in cases. The hypothesis is that it's the flame retardants, the PBDEs, in our household products, our sofas and chairs and rugs.
Yeah, it wouldn't surprise me that without question that's one thing that has changed over the decades, the amount of environmental toxins that we're exposed to. And it's not only the direct effect that it has on our hormones, but also when we think about Graves' disease. Again, Graves' disease is autoimmune, and one component of autoimmunity is an increase in intestinal permeability, which is a leaky gut. And many of these environmental toxins can cause that leaky gut, such as glyphosate.
So what do you do? I mean, what did you do, not just for yourself, but what do you do for your patients who are complaining of Graves' disease or other forms of hyperthyroidism? Can you tell us about your 6 steps?
Sure. So everybody, of course, is different, but there is, of course, overlap as well. Just like with any healthcare practitioner, we do a comprehensive health history, and testing also plays a big role. So, but I will say that just probably with all chronic health conditions, diet is huge, diet and lifestyle. So that's, the starting point would be the health history with the patient. But when they speak with me for the first time, while going through the health history, we talk about diet, we talk about lifestyle. I know in my case, stress was a huge factor. So besides cleaning up my diet, because my diet also wasn't perfect when I was, nobody's as perfect, but it definitely had room for improvement. But stress was, I think, a huge factor, or I should say, I know was a huge factor. And it's not just the emotional stressors. I'm pretty sure I was overtraining. I was exercising too hard. So that was a stressor. I had my adrenals tested, and things weren't looking good with my adrenals. So in my case, and with many of my patients, diet, stress management, making sure they're getting sufficient sleep. But then I'm also a big advocate of doing some testing to look and find some of the potential triggers and underlying imbalances. And again, that's where I mentioned adrenals. So I did some testing for adrenals. In my case, I utilized saliva testing. These days, I still use saliva testing, but there's also dried urine testing, sometimes a comprehensive stool panel to see if there's parasites or H. pylori, which again in the literature has been shown to be a potential trigger of Graves' disease, and blood testing, of course, but it goes beyond the basic blood testing. Most, when you go to an endocrinologist, they'll of course do a thyroid panel, and hopefully for someone with hyperthyroidism, will test the antibodies, specifically the thyroid stimulating immunoglobulins. Then they might do other tests like the radioactive iodine uptake test. But I look deeper into the blood test, so I will look into, I'll do some of the basics too, like a complete blood count and a CMP, comprehensive metabolic panel. But I'll also look at some of the nutrients. I'll look at vitamin D is very important. And unfortunately, many medical doctors won't test for vitamin D, important for not only healthy bones, but healthy immune system. And, I also sometimes will test for viruses like Epstein-Barr I mentioned earlier. So that's a big part, is just trying to educate the person I'm working with as the importance of diet, lifestyle, but then also trying to do some testing to look for potential triggers as well as underlying imbalances.
Dr. Osansky, you've really stressed the importance of diet. Can you tell us what diet is optimal for someone with Graves' disease?
Well, I can't say there's a perfect diet for everyone. And I mentioned that earlier, but to me, it all comes down to whole, healthy foods. Now, there is what's called an autoimmune paleo diet, And I will say that with many of my patients, that's a starting point, not for everyone. If someone's a vegan, vegetarian, then we usually have to make some modifications. But either way, we want, whether the person is a vegan, vegetarian or not a vegan, vegetarian, want them to eat whole, healthy foods, avoid the refined foods, avoid fast food, avoid sugars, unhealthy oils, plenty of vegetables and, some fruit. So again, like I said, autoimmune paleo or AIP is usually a starting point, and some will find that too restrictive, so we might just do a modified AIP or a paleo diet. So it really does depend on the person.
What about natural treatments? I know that, a standard endocrinologist is going to recommend radioactive iodine, or they may recommend medication, or they may recommend surgery. First of all, are there differences between Europe and the United States when it comes to treatments? And then what about your approach in a more natural way?
Yeah, so I do want to say there is, of course, a time and place for the conventional treatment methods, and a lot of my patients will be on anti-thyroid medication. I personally did not take anti-thyroid medication, so I took an herb called bugleweed to help manage the symptoms, along with something called motherwort, and a lot of my patients take the herbs. But I do have a good number of patients that take anti-thyroid medication, such as methimazole, sometimes PTU. And as far as the question in Europe, anti-thyroid medication is commonly recommended in Europe as well. That they take frequently. It depends on the location, but like carbimazole, which converts into methimazole. I will say that there are doctors that will recommend radioactive iodine thyroid surgery in Europe, but a lot of times they are. Let's put it this way, in the United States, many times they're more aggressive with those treatments with the radioactive iodine thyroid surgery than they are in Europe. But it does come down to the doctor too. I've worked with patients remotely in Europe who also their doctors are pressuring them to get radioactive iodine thyroid surgery. And even though this isn't ideal, some endocrinologists, some doctors in Europe are more open to long-term methimazole. Like here with the anti-thyroid medication, typically, the endocrinologist will tell the patient that they'll be on the medication for 18 months to 24 months and hope that they get into remission. And if they don't get into remission, then the next step would be radioactive iodine thyroid surgery. It's more common in Europe where they will have they'll allow the person to go beyond the 24 months, maybe even take a very low dose of methimazole or carbimazole, like 5 milligrams long term. There's also something called block and replace therapy, which you don't see too much in the United States, but you do see more commonly in Europe. Again, I wouldn't say most people, but here it's rare. And with the block and replace, that's where when they give, let's say, carbimazole, especially the higher doses, let's say 40 milligrams, it's very common for the person to switch to hypothyroidism. So in addition to the carbimazole, or again, methimazole, they'll give thyroid hormone replacement, levothyroxine. So it's kind of like balancing it out. Of course, they're not doing anything to address the cause of the problem, but it's just a different way of managing the symptoms.
Dr. Orsansky, you've mentioned bugleweed and motherwort. Are there any other natural approaches, any other vitamins, minerals, or herbs that might be helpful for Graves' disease?
So some people will take lemon balm. So lemon balm, it has like a calming effect, maybe some mild antithyroid properties. And then there's L-carnitine. So L-carnitine in higher doses, the research shows 2,000 to 4,000 milligrams per day can help also with the elevated thyroid hormone levels. And then when it comes to the immune system component of Graves' disease, I mentioned vitamin D. Healthy vitamin D levels is important for a healthy immune system. There's a lot of research with selenium too. Selenium with Graves, and then a number of people have what's called thyroid eye disease, which is also autoimmune, but it's where the immune system attacks the tissues of the eyes. And selenium also can help in some cases of thyroid eye disease.
What's the dose of selenium? Because I know people can overdose on it, but it's not unusual for people to not get enough.
Yeah, sure. You're correct. You don't want to take too much. So a standard dose is 200 micrograms. That does seem to be safe. Some people might be able to go over that, but I would rarely do we see someone have problems with 200 micrograms of selenium.
Does Graves' disease ever go away?
So if someone doesn't do anything to address the cause of the problem, it can go into remission, and that's what most medical doctors are looking for, just putting the person on antithyroid medication and hoping that it goes into remission on its own. The problem is it's not addressing the autoimmune component, so a lot of those people will eventually relapse.
You mentioned intestinal permeability. Some people call it leaky gut. Can you tell us a little bit more about what it is, why it impacts the immune system, and what you can do to reduce this problem?
Yeah, so with the leaky gut, you have a compromised intestinal barrier, and with the problem with not just the leaky gut, but most of the immune system cells are located in the gut. So you need to have a healthy gut in order to have a healthy immune system. And what we see a lot of people do when they suspect they have a leaky gut, you can do testing for a leaky gut, but most people will just assume that they have a leaky gut. And if that's the case, they'll take agents or eat foods which can help heal the gut, which isn't a bad idea. Things like L-glutamine or drinking bone broth. But you also want to address the cause of the leaky gut. So if someone is eating gluten, for example, which can potentially cause that leaky gut, then of course you want to eliminate gluten. If someone has a gut infection, then they want to do whatever is necessary to eradicate the infection. So it's important to there's something called the 5R protocol, and the very first R is remove. So you need to remove the factor that's causing that leaky gut, and then you can move into the other components, the replace, the reinoculate, the repair, and the rebalance components of that 5R protocol.
Dr. Osansky, in your book, you wrote about a person named Keisha who had been self-treating her hypothyroid condition. Can you tell us why that's not a good idea?
Yeah, it's as I mentioned earlier. I think it's okay to make dietary changes and do things from a other things from a lifestyle perspective, like stress management. But when you're trying to find your own triggers and underlying imbalances, it's a challenge enough, even when working with a healthcare practitioner, but even more difficult on your own. And some people might do things that could potentially make things worse. So Joe mentioned selenium. So if someone takes too much selenium, or there's a lot of controversy with iodine as well, and someone might just look and see that iodine, could help, and iodine could, in some cases, could make things worse. And there's a lot of things that could go wrong. So from a diet and lifestyle perspective, I think there's a lot people can do on their own when it comes to taking supplements and trying to figure out their own triggers. It could be challenging. And in some cases if they take the wrong supplement, the wrong dosing, it can potentially make things worse.
Speaking of iodine was what caused my Graves' disease. I had a abdominal obstruction. The physician ordered a CT scan with contrast, and that contrast was iodine, which it often is. And about 4 to 6 weeks after the surgery, I was starting to feel uncomfortable, put it mildly. My hands were shaking, my heart was racing, my blood pressure was up, all of the symptoms that you described for your hyperthyroidism. And sure enough, when the tests were done, I was, in fact, hyperthyroid. The idea that iodine, in contrast, which is done quite frequently in this country with CT scans and with MRIs, could trigger hyperthyroidism comes as a real shock to a lot of health practitioners. Can you explain what that's about?
Yeah, there is concern with that. And this is actually in the research too when it comes to the iodine contrast agents, where iodine, it's funny because if someone has hyperthyroidism through like a negative feedback mechanism, taking higher doses of iodine sometimes can lower the thyroid hormone levels. And that's where it gets dangerous, because some people think that, that iodine is necessary, for hyperthyroidism. but there's also that risk where it could be a trigger for someone who doesn't have hyperthyroidism, but it also could potentially exacerbate the hyperthyroidism or the autoimmune component in someone with Graves' disease. So yeah, you bring up an excellent point with the iodine contrast agent specifically, because a lot of people aren't aware of that. And yeah, that's something that, I mean, I would definitely try to minimize, because you just never know. There's someone with Graves. I have patients every now and then asking me if someone's getting a CT scan, should they avoid the iodine contrast agents? And it probably is a good idea if you have a history of Graves' disease, but in your situation, obviously you didn't have that history and it became a trigger. So even if you have no history of Graves or other autoimmune conditions, but more specifically Graves in this case, or Hashimoto's, again, I definitely would be cautious.
We'd like to conclude our talk with you by asking about the action plan to restore health. If you can give us a quick summary and tell us how people can find out more on your website.
Sure. So as far as the action plan, of course, I'm going to be biased and recommend to see a healthcare practitioner that'll help address the cause of the problem. But whether you do or not, diet is very important. So I would focus on eating whole, healthy foods. Maybe look into an autoimmune paleo diet, or if that's too strict, even a regular paleo diet is a healthy diet. And stress management, again, is huge. If you can do things to reduce stresses in your life, that's great. But many people, that's a struggle. So you want to block out time for stress handling, try to do things to get sleep. It's a little bit of a catch-22 because a lot of people would love to get sleep. But so diet, stress management, other lifestyle factors like sleep, and ideally work with a practitioner to do the appropriate testing to try to find some of the triggers and underlying imbalances. And I think those are some good starting points. And one other thing I'll say is you want to be safe while trying to address the cause of the problem. So again, I took bugleweed and motherwort, but they don't work for everyone. So if for any reason you try the herbs and if they don't work, or even if you're currently taking the medication and if it's working for you and not really causing side effects, if the liver enzymes look fine, again, there's nothing wrong with continuing with the medication temporarily while trying to address the cause of the problem. Everything's risk versus benefit. So I do need to say you want to be safe while trying to address the cause of the problem.
Dr. Eric Osansky, thank you very much for talking with us on the People's Pharmacy today.
Well, thank you again. Thank you so much. And once again, people could find me by visiting my website, naturalendocrinesolutions.com, and then savemythyroid.com. That's where you could find my podcast. And my book is called Natural Treatment Solutions for Hyperthyroidism and Graves' Disease, which can be found on Amazon. And thank you. Thank you so much, Joe and Terry. I appreciate this.
You've been listening to Dr. Eric Osansky. He's a chiropractor, clinical nutritionist, and a certified functional medicine practitioner who helps people recover from autoimmune thyroid conditions. He's author of Natural Treatment Solutions for Hyperthyroidism and Graves' Disease and Hashimoto's Triggers. You'll find a link to his website in the notes for today's show under the podcast tab.
Earlier in the show, we spoke with Dr. David Cooper, Director of the Thyroid Clinic and Professor of Medicine and Radiology in the Division of Endocrinology, Diabetes, and Metabolism at the Johns Hopkins University School of Medicine. Dr. Cooper is the past president of the American Thyroid Association.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio WUNC with the People's Pharmacy.
Today's show is number 1289. You can find it online at peoplespharmacy.com. You can subscribe to our podcast through your favorite podcast provider. We post the show on our website on Monday morning. This week's podcast includes some questions and answers about motherwort, selenium, and intestinal permeability that we didn't have time for in our broadcast today.
At peoplespharmacy.com, you can sign up for our free online newsletter to get the latest news about COVID-19 and other important health stories. By subscribing to our newsletter, you'll also have regular access to our weekly podcast and find out ahead of time which topics we'll be covering. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.